Good afternoon and welcome to this Smarter Health Seminar. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research. Thank you for joining us today. I'd like to welcome our web viewers and the Ontario Telehealth Network sites. This seminar is being recorded and is being broadcast over the web. We ask that you hold your questions to after the seminar presentation so that we can get a microphone to you. For our virtual viewers, please send in your questions and we will ask them for you. These seminars are hosted by the Waterloo Institute for Health Informatics Research, the Lawson Health Research Institute, and the National Institutes for Health Informatics. We are also very grateful to our seminar sponsors, McKesson Information Solutions, ITAC Health, and Healthcare Information Management and Communications Canada. We could not host these seminars without their support. I have two announcements. The next Health Informatics Boot Camp will be held at the University of Waterloo from June 27th to 29th. Registration is open, so I encourage you, if you want to attend the boot camp, to please register soon. We are also holding the first Advances in Health Informatics Conference at the University of Waterloo's Health Sciences campus at the School of Pharmacy in Kitchener, Ontario from April 28th to the 30th. This inaugural international conference will feature exciting keynote speakers and presentations from thought leaders, visionaries, researchers, and entrepreneurs around the globe. EHealth 2010 will be an innovative green conference in that participants can attend in person or by the web. It will include an interactive think tank session on the current eHealth situation and strategies for going forward. I encourage you to join us in this first global virtual health informatics conference to be held in Canada. And so for more information, there's the URL on our slide, ahec.nihi.ca. So, why are we here today? We are looking at the new theme of around the eHealth crisis. We'll look at this topic from many perspectives with the goal of understanding what the issues are and what we can do to solve this crisis, which is happening not only in Canada but around the world. So our schedule for today is as follows. Our speaker will speak for about 45-50 minutes. At the conclusion of his presentation, we will have a facilitated discussion where you can get to comment and ask your questions. So as I said before, please hold your questions to after the presentation and we'll get a mic to you. We invite our web and teleconference viewers to send in their questions as well. So it is my pleasure to introduce our guest speaker, Mr. William Pascal, who brings a wealth of knowledge and experience to bear on the topic that we are examining today. Bill is the Chief Technology Officer at the Canadian Medical Association, where he has the responsibility for shaping the strategic direction and policy for the CMA's eHealth agenda. He has worked in the economic policy and social policy sectors at the federal government level, as well as run operations in regional and headquarter environments. He has been responsible for the communications policy while at the Privy Council office and in Health Canada. So he has developed health policies and managed the central region operations for Health Canada, which included Ontario, Manitoba, and Saskatchewan. More recently, he was the Director General, Office of Health Information Highway, which was responsible for coordinating, facilitating, and managing health infrastructure-related activities, both within Health Canada and with other federal government departments. His work led to an agreement on information technology investments in the healthcare sector in Canada with all provinces and territories and the creation of the Canada Health Infoway. He is an electrical engineer. We won't hold that against him. Certified management accountant and urban planning by academic training. The title of Bill's presentation is eHealth, Refurbishing a Tarnished Brand. I'm looking forward to this presentation very much, so please welcome Mr. Bill Pascal.
Good afternoon. Not sure what the electrical engineering slur was, but there are a lot of very good electrical engineers in this country, I want you to know. So if we can... So what I want to talk about is where the eHealth agenda in Canada has come from, where are we, where we're going. But my interest in this is because I worry about where we are in Canada today with the whole EHealth agenda. And and when you talk about it, the EHealth now has been contaminated for a whole lot of reasons, some of which are real and some of which are not. And I'd like to take you through some of that thinking and also sort of our thinking on, so where do we think the agenda in Canada has to go? So I'm going to take you through sort of three parts of this presentation. So if you've been looking at the news since April of last year, we've had a series of audits that have come out across the country. In fact, 6 audits at the provincial level, 1 audit at the federal level, and we have 1 more audit that's going to come out of PEI actually this coming week. These are the headlines that came out of it, and I could have actually filled about 10 slides with the headlines. And they also give a sense of EHealth, bad. EHealth, not so good. EHealth, should we keep doing it? I put my old communication hat. First of all, you've got to understand that the newspaper is only going to pick up those parts that aren't good. But to some extent, this is real. I mean, this does reflect some of the issues that we've got there. If I take you into the actual reports, so I read them all and I said, so what are the general themes that are coming out of the reports? And this is what you start to see. A lack of an overall strategic plan to guide where we're trying to go. Missed targets. In fact, if you take a look at them, there is not a component part of any of the plans put out by the provinces or InfoA that has actually met the targets. I guess the other question one has is, or at least I've had, is can I identify the targets, which is in some cases difficult. None of the provinces can accurately identify all the investments in IT. What actually fits into the EHealth bundle? Lack of transparency. So what are we actually doing in EHealth? And I have actually gone in to take a look at all the EHealth strategies of the provinces, and sometimes I'm still having difficulty understanding what pieces are actually in there. The last one in particular, very little has been done to measure benefits. And I think I want to come back to this because I think this is one of the lacunas we have in this agenda is how do you measure, are we getting value out of all the expenditures that we are doing? And this has led at certainly a senior management level, a decision-maker level, does an EHealth agenda still make sense? I mean, we've got all sorts of questions. And I guess the other thing to consider as well, April 20th, there's going to be another report come out from the Federal AG plus six of the provinces that are going to wrap up an overall sense of what has happened with the EHealth agenda. And I think if you just take a look at these themes, that's what you're going to see them commenting on. So once again, we're going to have another series of editorials coming out on is the EHealth agenda in Canada still worth it? So we've got EHealth, a tarnished brand, and what we have to do is figure out how to bring it back to shape. Because I personally believe that the EHealth agenda in Canada makes sense. Do I believe that it makes sense currently how we're doing it? No. I think we have to make some adjustments, and that's what I want to share with you today, is sort of some of my thoughts on it. So to understand where I think we have to go, I want to take you back to, so where did we start with this, and what actually started to shape it, and where have we gone over the last 10 years? Back in 1999, when I was with Health Canada, this report came out. It came out to Alan Rock, who was the minister at the time, and it basically laid out a plan to go forward. And fundamentally, what was in the plan was actually not bad, and that we should be actually bringing IT in to support the care processes, capturing that data for clinical purposes, capturing it for research purposes, capturing it for system management purposes. And out of this, what we did is we had developed a plan which we had got all the provinces, territories signed on that said, here's the things that we should do. And I think if you looked at that plan, you would find, putting EMRs, EHRs, telehealth, taking a look at some of the networking issues we needed. Nothing unusual. But we didn't exactly follow the plan. But at the time, the reason we were able to get the provinces and territories and the feds lined up, we had an alignment. Syzygy is an astronomy term which basically means the planets line up. And at that time, I think this is it was 2000, 2001, we got the deal signed on with the federal, provincial, territorial groups. Fiscal health of all the provinces was really good. They had all come out of debt. They were all in a positive position. They were not under pressure with their healthcare systems, and actually they were very buoyant, and even the federal government at that time. What we found with the deputy ministers and ministers, there was a growing awareness that ICT was one of those key components that had to be invested in to actually support the healthcare system. And it was done under the premise that it was going to lead to productivity. And I'll come back to that too, because the promise was there. We just haven't delivered on the promise. The other thing that came out is that we actually started to have jurisdictions wanting to work together. And when I say share risk, that was actually going out on the market for RFPs, doing things jointly. The first time the CIOs in this country got together was in 1999. Up to that time, CIOs, the question was, well, why would I come to a meeting to talk to some of my colleagues? It was very much a jurisdiction-by-jurisdiction agenda. And in fact, if you looked at the agenda, in fact, most of them didn't have agendas. You had regions and people doing some very interesting things, trying to incorporate IT into business processes, but we weren't getting the cooperation across. But that's what we started to find out. So things did align, where you actually started to bring people who had common interests and a common agenda together to want to work together. And from a public policy point of view, very, very important to sort of drive this agenda out. What happened is the discussions we had with the provinces started to talk about these types of things that we felt were necessary to bring in. And this diagram actually was created by Canada Health Infoway to try to show how the pieces of the puzzle would, over time, fit together. I want you to look at this, though, because this also became the guide on how the investment in Canada Health Infoway was going to be made. So when I left, we had just gotten the first $500 million into Canada Health Infoway. The total now is $1.6 billion. We've just gotten another $500 million approved, and by today they should be signing the agreement to release it. So Infoway will now have $2.1 billion. Sort of view this as probably the provinces have doubled up on that. The funding isn't exactly that, but if you take a look what the provinces are funding, we're probably double that expenditure. Once again, it's hard to figure out exactly what expenditures. But this is where the funding in Canada has been directed to over the last 8 years. So, and the point to remember is that if with Infoway with the money, every deputy wanted their piece of the pie. And so what they were willing to do with Infoway is take a look at their jurisdiction and start to look at investing in these areas with Infoway. And when Infoway got set up, it was 50-cent dollars. If province put up 50 cents, Infoway would. It got changed later on to 75-25, and that was more a matter of some of the smaller provinces, quite frankly, not having the fiscal wherewithal to sort of match the money, and we wanted to push it forward. So this type of programming had a steering effect as to how the dollars got spent. And the other observation I'd make is this is, if you'll take a look at it, it was building big enterprise. This was not a point-of-care agenda. And think about that, because I'm going to come back to that as we get on, because it gets into some of my issues with the current agenda and why I think we have to realign things. If you haven't seen this diagram, you've never been in the health business, you probably have been on the Survivor reality show and have not been booted off the island yet. But this is what has been out there and has been guiding the investment, which all CIOs are looking at and where we're trying to go with it. I'm not going to get into the details of it, but I want to come back to it because there is something here that I think we have to think a bit about, because it actually has skewed the way that we have been doing investment in Canada over the last 8 years. When you take a look at the investments across the country, this gives you a sense of where they're going. If you take a look at the legend on the far side, other than telehealth and a little bit diagnostic imaging, there is nothing at the point of care. Everything is in what I call the back office infrastructure. It's in the enterprise side. It's building the buckets to hold the information. But nothing is going on at the point of care. Now, it doesn't mean to say it wasn't. I mean, because you'll notice the EMR programs, there were some provinces that didn't all start in 2002, but over time we've now got 5 provinces that are actually investing in point of care applications. And when I mean point of care, primary care, specialists, could be long-term care facilities, etc. But what you see is that it skewed all the activity and all the funding. And it's skewed the time and energy of most of the people we have who've actually got the capability to manage these type of investments into the big infrastructure side of the business. And I'm going to come back to that because that has some other sort of implications for how we've moved ahead on this agenda. This gives you a sense of, given what I showed you before, those big expenditures, what by the end of March 30 last fiscal year, the goal that Infoway had set out is that 50% of the population would have some of their information in some of these data holding infrastructures. At the time this was done, it's 17%. Probably it's up to about 34% now, I think, of the latest figures I'm talking with Infoway. But once again, if you look at it, the only thing here that actually starts to potentially touch the patients is the clinical reports on immunization that gives you some sense of what is going on. Now, Infoway was in a difficult situation because they could not, while they could invest with the provinces, they were not investing in the point-of-care applications. So they came up with metrics around success of, we have the capability of building these type of data warehousing to capture data. But this does not translate into care. So even if you had all these bins up, if the province had not been able to do their investment in networking and putting point-of-care applications, you had no source data to go into it. And even when you did have source data, it was of little use. So as an example, in BC you have BC PharmaNet. It's the richest drug database in Canada. It captures every drug interaction or every drug and script that's been written in BC. Unfortunately, you do not, at the point of care, you don't have the applications to connect to it. So as a physician who's writing scripts, if you're not EMR enabled or if you're not connected to the BC PharmaNet, it is of little or no use. I guess the other thing, and as an aside, actually they charge physicians $100 a year to actually use it. When you think about it, the reason we got into it is because we're trying to deal with safer care, we're trying to manage the medication management issues, and I sort of wonder why we're going that way if indeed we are saying there's such a huge upside on it. So even when we got it, we had sort of funny policies and approaches which actually did not get down to actually increasing the value to the patient. So if I take a look at the last 8 years, these are the types of characteristics of the programs out there. And I'm being general here. I mean, some provinces have done some very specific things. But if I look across at the 10 provinces and I look at the three territories and some of the work done in the federal government, very much a top-down agenda. We're going to design what we want and we're going to deliver from the top down. In other words, we're going to build the enterprise side of the business. That's where we're going to put our time and energy. And because Infoway's money was tied to that diagram I showed earlier, it basically steered where the investments are going to go. So I think that steering effect actually prevented, this is my assessment, prevented more activity at the point of care. And you got to remember, provinces only have so much money. So if you're trying to match dollars to those bigger programs, I mean, you're going to take time and attention away from applications that are actually going to be at the point of care to deliver care. As I said, enterprise approach. We're going to build the back office first. We're going to get that done. The other thing it did, though, is it did create a lot of pan-Canadian collaboration, which I think was good because a lot of the solutions and the issues are very portable, are very similar in every jurisdiction. And the solutions are portable. And we have found that going out on the market with joint RFPs, we've actually driven down the costs of the applications quite considerably. And I think that's been a very positive aspect of it. However, in this case, the return on, and this should be return on value, because what I like to look at here is the quantitative and qualitative side of what do we get in return for this. This approach, however, means that until you have all the enterprise in place, and then you put in the point of care, you really don't start to get your return. And therefore, you're at least 5, if not 10, if not more years out before you can start to really get the benefits and the gain into the care system. There was some really good work on standards. In fact, that was another good part of this where we brought people together to develop standards. And actually, there is a good suite of standards that is out there now. I hope that we continue to invest in this because that is one of the things that we should be driving for. The downside of this, though, is every standard that's developed, every province has tweaked it a little bit. So now if you're a vendor, and let's say you've got a drug system and you've now put the drug system in Manitoba, and you want to then go and bid on the drug system in Saskatchewan, you actually have to do some retooling, a reprogramming of your solution, which is time-consuming, costly, and to some extent we sort of thwarted some of the good work that has been done on the standard collaborative, because we're now forcing vendors to have to be spending a lot of extra time and money to sort of fit into it. And if there was one really shortcoming, this is it. And quite frankly, I don't understand why we have to do some of the things we're doing there. It's a high-risk agenda. You're building big applications. And all the research on IT says the bigger the application, the more complex, the higher propensity for failure. In fact, the stuff Standish has done, clearly shows that there's a somewhere. I think it's gotten better now. The last time I looked at it was back in 2004. I think they've done some updates, but you're looking at about 35%. I don't know. I'm looking at you, but about projects actually fail miserably. You got another sort of 30 to 40% that you get part of your return on your investment, and you get and then another 30% where actually you get a good return. So. And it's not because you don't have good people. You've got some very, very smart people working on this stuff. It's extremely complex. So the approach they've taken actually does put it high risk, which is in many cases why you've got slippage, because you're finding problems, bugs. It's costly to go into it. In fact, as you get into it, you find that your costs actually have a tendency to increase and are tough to manage. But this whole agenda put little by way of attention on the point of care. Some provinces have done it. I'm not saying they haven't, but fundamentally, the way that we funded it and steered it once again pushed up here and didn't get pushed down. And the consequences of is that even when you have built the back end, you still now have got that adoption curve for the people at the front end, the clinicians. And once again, you look at diffusion theory on that. It's going to take anywhere to 5, probably 10 years to bring those people on. So even if you had the rest back here, you're still waiting another 5, 10 years to start to really achieve your full sort of return on value equation. And once again, very low patient value. What I mean by this is improved care, safety, access, those types of measurements. There wasn't a lot delivered. So what does that, let me now, so that's sort of what's happened over the last 10 years. Now let me bring you into sort of where we are today. So I'm going back to this diagram. Fiscal health. It's in the tank. In fact, if you looked in the Globe and Mail today, there was actually a really nice article that showed sort of the deficit position of all the budgets that have been released today for 2010 and what had happened in 2009. Only 2 provinces are going to come out with a balanced budget. That's going to be Alberta and Saskatchewan. And the reason they're doing it is they're dipping into their sustainability fund to actually basically balance it off. What this means, though, is that every province now does not have the same degree of flexibility in their budgets that they've had before. And it means that you're now going to start to look at what can you afford to do. IT awareness, certainly up. Every deputy minister I talked to, every CEO I talked to said, we know we need it. They're not quite sure how to do it, though, to get the return on value. I mean, once again, everybody on the system manager side has looked at this as how do we improve productivity? It's an elusive goal, to say the least, and how we're doing it. And we've gone from shared risk to risk aversion. And part of that is because the tales that have come out of difficulty, missed targets, increased costs, and now you're seeing people saying, especially the decision makers, why should we go down this route? I mean, part of the reason that the money from Infoway was delayed is that concerns of ministers on, are we going to get value for this money? Are we going to be able to use this money appropriately? And so it's not that provinces won't work together, but there is this with decision makers saying, is it worth the investment going forward on this thing? There's 2 other things that are happening now that are really going to have an effect on sort of the type of decision maker we're going to see. And there's 2 tsunamis. Now, you may notice I looked at this, and these people seem to be smiling and about to be hit with a 30-foot wave, so I'm not quite sure that this, or maybe I chose the wrong one. The first one is the fiscal meltdown, and we're going to talk a little bit more about that. But basically what that means is the degrees of freedom within provincial budgets is now gone. I mean, and I'm going to show you some slides, but basically healthcare eats up anywhere from 40 to 45% of the budgets of provinces now. and it's growing at somewhere around 6%, which none of the provincial budgets can deal with. The second thing is the demographics, and what I mean by this is the growing costs. We have an aging population, and we know that they put more demands on the system, more drugs, more support. If I talk to my primary care colleagues, the types of the issues that they're facing in the office are more and more with patients who have multiple chronic diseases, and how do you manage that? And it is taking more time of the care teams on this, and it'll only get more aggravated and more pressure on the system as we take a look out of how the demographics in Canada is going to change. So if you take a look, and this one only goes to 2008, but I can tell you going into the figures of 2008, 2009, you see the growth of the percentage of provincial health spending on total provincial programs. What has happened over time is that the growth in the healthcare sector has decreased from 8%, I think it's down to about 4.5%. There's a prediction in Ontario that it's about 6%. But if you're a minister of health and you're around the cabinet table and you're trying to argue saying my budget needs 6% more because that's just it's wages, it's drug costs, it's other operating costs, and your colleagues are looking at you like, why do we want to give you more money when we got education? I guess if you're the federal government, you want to build more prisons, depending where you are. You have a tougher time convincing your colleagues that you need more money. The other thing, if you take a look at it from a demographic point of view, and this is in comparison to working age people, when you take a look at the costs. So just up to 2020, you can see the increase in cost for people who are working to support our system, which means more of our people move into a retirement mode where there's going to be more need for taxes and revenue streams to actually pay for the healthcare system, assuming we don't make any changes, which I believe we're going to have to make some type of changes in what we're willing to cover, what we're willing to pick up in the healthcare system for the flexibility. So let me just back up here. What that tells me is that we have to rethink how we want to move forward on the healthcare agenda in Canada, because the way we're moving at it now doesn't help us get at the cost issues that all provincial ministers of health have, doesn't help us get at the demographic issues of the shifting health of people and the more demands that they're placing on the health system for support anywhere in the short term. Because if we continue, my thesis is we continue with the current top-down, we're probably 10 years out before we're going to start to see real value being brought into the patients. Now, some problems will do it quicker, but I'm thinking overall we got a long way to go before we start to be able to start to measure some real value when it comes to patients and improve patient care, improve safety. The other part of the problem I've seen is that the current agenda doesn't really reflect the business requirements of healthcare. And what I want to put in front of you is a little different way of looking at, so how is healthcare delivered in Canada? And if you're going to bring IT in, should we not be supporting that the way care is provided? Should we not be investing where we can start to actually maximize some returns early in the game as opposed to trying to wait till we can turn on the whole system, which, by the way, we don't know will work when we do turn it on. And my probability would be that we'll have great difficulties with it. And there's been a number of systems that have been turned on, and we're still playing with them to try to rectify the issues. So let's take a look at what happens in the healthcare system. This goes back some information actually Cal Finway put together, and it gives you a sense of the volume, and let me call these healthcare transactions. These are events that happen as you move through the healthcare system because you've had an encounter with your primary care doc or your specialist, or if you're in a long-term care home and you've been sent on a healthcare path. These are the types of things that you've been asked to get into. So you've got your diagnostic imaging tests, lab tests, hospitalizations, the number of scripts that are written, the number of office visits. The majority of these take place in a community level, in a local level. They don't take place up in big systems. They take place at a very localized level. And let's give you a different look at it. And I mean, one of the things here, what we're really trying to do is improve information liquidity. The health system works on the generation of information and sharing that information. Right information, right place, the right patient, the right physician, the best care. That's what we're trying to do. It doesn't mean all the information. It's trying to get it into there in the right place. How do we actually get at this? And I think there's some questioning here of the approach we've taken in the past. I don't think helps us do it. And I'll talk a little bit about that. If you go back to a report in the New England Journal of Medicine back in 1961, what they did, they called it Ecology of Medical Care. They said when 1,000 people hit the system, where do they actually get, what happens? And what you'll see in this, and I apologize for some of the smallness of it, what you see is that probably less than 5-6% actually get into an acute care. Most of their care is at a very localized level. It's interacting with their primary care level, maybe going to the pharmacy to get their script filled, maybe going to a lab to get some lab tests done. Maybe it's going to a physiotherapist. Maybe it's some work where the long-term care home. It's at a very localized level. Very few people go outside of their normal catchment area when they get their care. In fact, when they do go, it's usually they've been referred. You know, the specialist may say, because of the nature of your medical condition, we want to send you to Toronto because they've got some specialists there. But normally it's a managed transaction. Very few people go out of their catchment area to get care. And I raise that only because there is, we'll get into this later, you're trying to maximize your return on your investment. We can't solve all the problems in the healthcare system with IT, but we should be trying to look at where we can get the maximum return on our value by the type of investments we make. And I'll come back to that. This is a slight different diagram, but it actually deals with Ontario. So it goes back to the ecology. If you take a look at Ontario, and this is one day number of transactions in Ontario, so there's 247,000, and you start to see, well, where do people interact? So and if you take a look at those figures, less than 6% actually get into an emerge or get into a hospital. Once again, it's all out in the community. That's where the majority of care transactions are taking place. That's what clinicians, that's where they need their information flow to be to move it around. And what this begs the question of, do we need to really build a big EHR if majority of care is actually provided locally? And in fact, our assessment is anywhere from 85 to 90% of care is very localized. And if I can actually enable that capture and movement of that information at a very localized level for actually a small percentage of the cost, which I'll get into, is that not a better way in the next sort of period of time to sort of invest as opposed to trying to build the big of what I call enterprise and then later on getting it in there? So let's take a look at, given where care takes place, how it takes place, let's map that into sort of what's going on with the agenda in Canada today. So on the left is what I showed you, that detailed diagram. I've just generalized it to what they're trying to do. Once again, majority expenditures are all up here trying to build that. The intent is to put some more time and energy in the HIAL, and that's the integration layer. But quite frankly, not a lot has been done on that right now. In fact, that would be one area I'd say we should be putting all our time and energy to. So if you take a look at the health agenda on Canada, the area under that triangle basically is where the money's going. So it's going into the building the enterprise back office side. If you take a look at where care is provided, it's actually down here. But the problem right now is very little of the spend is going down at this point. And this is where the clinicians interact with the patient. And our argument is what we have to do is realign this. So if you look at this is very much a top-down agenda. We know what we're going to do, we're going to push it down, and we're going to give you what you want. Albeit, the things you have to think about is care is half science and half art. And it's an area where a lot of the interventions that take place now don't have any scientific underpinnings yet. A lot of it is based on a lot of people practicing and doing things, saying actually it showed improved care outcomes, therefore we're continuing it. The research is filling in the gaps, it's helping us understand better, but we still have a lot of what we do which is more of an art. You interact with your physician is reading you, is trying to understand what's really going on. What are the issues? We need to be taking a look at how do we support that part of it, we don't, without having to, well, we're not needing all what I call the big infrastructure in the back. And this is where I come to more from a business point of view. Having worked in a couple of small businesses and friends with it, I mean, we always took a look at, actually, we can get a big return on our investment by focusing on the 2 or 3 things that really matter. It doesn't mean we might want to spend on all the business processes, but there's principal ones that are going to give us the biggest return. And I think the healthcare sector is in the same boat, is that there are parts of our system that if we invested in, we will actually cover the majority of the healthcare transactions that go on. So you go back to where our thesis started from. 85%, maybe as high as 90% of the transactions are very, very localized. And we can map those fairly well as to what happens with the people and how they go through the system. What we're in the assessment that actually Health Canada or Infoway did, they said about 20% of the cost of the build in Canada, and it's estimated anywhere between about $10 and $11 billion, actually would IT enable the points of care, and that would be primary care, that would be specialist, taking a look probably at some long-term care facilities. And that would actually put in place what we need. If you added in some local interoperability layers, which, having spoken to a number of companies, it's not all that expensive, you actually start to, in a catchment area, start to connect all the points where a patient is actually moving through the system to receive their care. So if you start to think about it, over 85-90% of the healthcare is delivered at a local level, and these people don't have to go out of there. That less than 20% of the cost would actually enable that part of the system. And so we're talking EMRs, integration layers, and we're probably talking some software to smooth out the flow of information. Coupled with, when I actually talk to doctors, those that have actually a totally EMR-enabled environment, they say to me, actually, I'm getting anywhere, some of them say about 60%. I had a couple of doctors tell me it was 90%. That even without being connected, actually, this is the type of value they think they're bringing to the patient. Because now they're able to, if you think about it, an EMR has a medication management module in it. So you're dealing with your drug interactions, your drug allergies, your stuff. I mean, actually, you're printing the script out so the pharmacist can read it, because we're not into e-prescribing yet. But even that saves a problem. And actually, in behind, you got a clinical decision tool that's helping you sort of figure out what drugs you want to put in. Also in there, you're doing a better job on prevention. And so these physicians that use this are actually doing a much better job with the diabetics, because now they're actually meeting the prevention targets. They're doing a better job of reminding diabetics of what's going on. So every physician I talk to that's have an EMR-enabled clinic are saying, I know I'm doing better with those types of patients. Now, this is an area we have to do more because we haven't done a lot of applied research here, but that's an area that I'd like to push. The other thing that when we talked to the clinician gang, they said, if you can give me 3 things, now you've really taken me from 60% probably up to 90%. If you can connect me to the people that I send my patient to, so a primary care physician to a specialist or the specialist to the hospital and the discharge summary comes back, or when the pharmacist fills the script, there's a message that comes back to the physician, say, oh, by the way, your patient actually filled it. Won't tell you if they took it, but at least you know it's filled, so you've got part of that. If you can give me drugs electronically and give me labs electronically, basically I've now got almost all the information I need to manage my patient population. There's other little things you gain as you grow it out, and don't get me wrong. But what we're saying now is actually the value proposition to the patient has gone up quite considerably. And actually, by not doing a lot of investment and dealing with what I call some pretty low risk investments. So if you take a look at it, what are we talking? An EMR. We've already put in place probably about 10,000 EMRs in Canada. So what we figured out is that, as you'd understand in any implementation of IT, there's an adoption hump. We've actually figured out how to reduce the amplitude of that frustration, if I can call it that, for offices to go in. So I've had physicians who say in a week after putting the EMR in, they're up and running. I've had others that take a year, and some of them are because you got teams. You may have 10 doctors or 20 doctors, and it's usually more a matter of getting the governance in that group sorted out than the IT. But what we do know how to put these in. It's low risk because it's about $40,000 a pop per doctor. So even if one failed, the rest of them can still function. We're not in a high risk where you build a drug database and you go to turn it on and it doesn't work. Or you turn it on and you still don't have any data in it. So it's not much use yet to you. If we look at this, our view is there is a way to actually move this forward. We will get an accelerated return on value. And if I'm now a deputy minister and I'm looking at, if you look at Ontario now, what they're talking about is next year they're going to restrict the growth in the healthcare sector to 1.9%. And it's going to grow 6% is the prediction. That will mean that every deputy minister of health and health minister is going to have to take a look at, where do I cut back, what do I deal with? IT's, in my mind, is on the agenda. If I can go and say, for this, I can actually start to help you with your medication management issues. I can start to help you with your chronic patients and how we do it. If you take a look at Ontario with their family health teams, they've actually been able to pick up 250,000 orphan patients who have been partnered up with the primary care team. So you're getting at access issues, you're getting at better time management issues. And this can be done quite quickly over the next probably 1 to 5 years. And the reason I say 5 years is that the bottleneck on moving this forward is actually the ability of the EMR vendors. They only have so much capacity to sort of put into place. In fact, that is an issue unto itself, is that we do have a lack of IT smart healthcare people. And it's not because, it's just a numbers issue. We need more people that actually understand IT and understand healthcare to come in and help us move through this. But in 5 years, we fundamentally could have basically all the points of care done, the local networks in place, and we'd be dealing with the majority of the care issues in Canada, and for less than 20% of the cost. And I think, given the problem we got with on the fiscal side, we've got to start to take a look at it. So you've seen this diagram before. Have you seen this diagram? It's just inverted. Now, in Western societies, we have a tendency to read from the top down. So what do? We place emphasis where? On the top. So if you look at this diagram, we're looking at the jurisdictional infrastructure, the enterprise infrastructure. If you look at this, we're starting to take a look at the point of care. And if I take you to the next step in this, that's where I think we have to focus. The fundamentals of the architecture, the fundamentals of what we're trying to do with the architecture, which is capture information, make it available, improve its liquidity, getting it to the right place, right, I think fundamentally is right. How we're going at it, the question I have is, we designed this architecture in 2002. Technology has moved on. If you think back in 2002, we thought we were going to have a data storage problem. I think in 2004 we solved that. In fact, our problem is not we have no more problem with data storage. We didn't have cloud computing back then. The unit cost of doing some of the services now is much different. And we had a model where provinces were going to set up and run this. I guess my question is there different ways that we can come at it that are lower cost? That we can actually leverage some of the new thinking that's come out, some of the new innovations, some of the new ways of running the business that we haven't thought in the past. But this is the part, for me, that if we can get this right over the next 3 to 5 years, we'll have made huge gains in the healthcare system. We'll have created some flexibility for decision makers to actually do other things. So, for instance, if you better manage your chronic patients and push the care upstream, and what I mean by that is doing more on prevention and promotion, and also enabling those patients to get more active in their care. That means we have less people hitting ER, which means we give more flexibility to the hospitals to do the things that they need to be doing, which is caring for high acuity patients, and not patients that show up in ER because they're not feeling well, because we haven't done a good enough job of helping them manage their chronic issues. And the other thing in here, and the other piece that I'd like to see, is we do it at a regional interoperability layer. So, and what I mean by this is the architecture you've seen before has talked about the Health, so we're going to have that at the provincial level. Why can't we do it at the regional level? why can't we drive out a standard on interoperability? Because we got about 85% of the standards already developed. We go lock a bunch of very smart people in a room for 2 weeks and say you can't come out until you come out with a standard. And you pull something out. Now, it may not be perfect, but I guarantee we'll be pretty close. We'll have a really good standard. If we set up a fund across Canada to say, we will now fund regions that want to put an interoperability standard that meets this standard, and that is to connect all the what I call the normal localized care issues. So, the pharmacies, the labs, the primary care physicians with the specialists and into the hospitals through a localized. We've now covered off majority of the care process and the care that we need. When I talk to the vendors here, they're telling me we can do it. I mean, one of the questions for me, am I being sold something inappropriately? But I'm seeing it happen. I mean, there's products out there where it actually is in place and working. This actually moves us this agenda a lot quicker. I think, I know I've had some conversations with folks that have pushed back on me against it, but quite frankly, I don't see why we can't do it. Just so a reality check here, in Canada, we probably have about 35% penetration of EMRs into physician offices. However, only, and this is the Commonwealth study, and we're only about 14% of those that are really using it for the care encounter. In other words, you come in, it's all captured electronically, they're generating your script electronically, they're working with you. We still have a long way to go in Canada on the EMR investment front. We have about 45,000 physicians that will need an EMR. About 30,000 of them are general practitioners, about another 15,000 are specialists. If you take into account the physicians that already have an EMR and are using it appropriately, you take into account the 5 EMR programs I talked about, the money that's already there, we still probably have to find enough money to put another 25,000 physicians and get their offices EMR enabled. And that's where you get into the probably the biggest cost in this. To move this ahead, what we're arguing is there's 3 interim objectives that we have to look at. We've got to accelerate the adoption at the point of care. And this is primary care teams, it's long-term care, et cetera. And we got to actually ENR enable their offices. The second thing, we got to increase the ability to accelerate the movement of information. And that's where we argue, so the interoperability layer provides that ability to move it. And we're probably going to move information in its current structure. Ideally, what we want to do is get the semantics sorted out. But when I talk to the clinicians, they say, if you can give me what I already get electronically quicker, that's a huge move forward. And as we get some of the semantic issues done, then we'll put new versions of the product out and upgrade that. And we think that is a doable thing. But the other key thing is, if you put the tools in the office, are they being used effectively? And that's one of the areas that we think we need to do some more work. So if you take a look at the left-hand side, what we're arguing is that we need a large investment in points of care. Very definitely you need more money in the change management. I mean, if you go to Kaiser Permanente, if you talk to the CEO there, CEO said we probably should have put 3/4 of our money into change management and 1/4 of our money into the IT. Because that's where the biggest challenge was, and that's where we have to take more time and energy. And you'll find most of the programs in Canada put most of the money in the IT and a smaller percentage in the change management. Down here, national standards on interoperability. Couple that with some funding that actually allows for local interoperability solutions to be put in place. Now, once again, based on the standard. In here, this is all deals with what works. It's interesting that we basically took a leap of faith back in 2009 that we thought IT was going to be useful. And since that time, I've seen very little applied research on what works. Infoway has done some funding, and actually we went and we investigated 20 clinics that were totally EMR enabled, and we actually looked at how clinicians were doing it, and we did find that there were some good outcomes as far as improving care and those things. But we need to do more, because there's lots of experimentation going across this country with some wonderful clinicians doing some neat things, but we're not capturing the experience as to what works and why. But taking it a step further and saying we're going to take that knowledge and turn it into a learning opportunity and push that out as a free good to every clinician to say, here's what your colleagues are doing to improve care by using these types of services. The other thing that I think becomes not a killer app, but certainly it starts to solve a lot of people's problems is what I call natural language processing. If you go to where the majority of information gets collected is in a primary care level, it's captured in textual notes and it's captured in data points. And every clinician does that a little differently. Yes, we'd like it more structured. I mean, certainly if you were a researcher, you'd want a greater granularity in the data you have, and you'd love the clinician doing the care encounter to do the drop-down boxes and get in and do all the stuff. If you were a system manager, you want the information slightly differently because you're trying to look at it from a cost management point of view and what you're getting in return, and you want a different set of information. What we really need to do is find a way to take that information that gets captured in the care encounter and with mind maps put it into structured data sets that actually support the clinical delivery, that support the system managers to do the stuff they want, and support the research community, in other words, the knowledge developers, and I use that term generically. If we do that, I think we really start to bring more value into the system. I guess the question I've gone to see a couple of actually solutions that are being used in more structured data formats in Ottawa University. In their breast cancer area, they've got a solution that they're using to map pathology reports into structured data sets. And actually, they say it's 100% accurate. And they've actually done an audit of it, and it says it's 100% accurate, so I can't doubt them. The point of the matter is, even if we could start to use this and get, let's say, 60% of the data that is captured at the primary care level in a structured data set, it gives us a richness that we don't have now. And to me, this is one of those things that really helps us start to address the issues that why we got into it. If you take a look at the healthcare system, there's 3 primary groups that want the information. The patient's in the middle, and the patient generates personal health information every time they encounter the system. The clinicians want it because they're trying to provide care and they need certain data points and information so they can actually diagnose and send the patient off on a healthcare path. The system managers want it, generically because they're trying to, there's a cost issue. How do we manage and are we getting the best return on what we're putting in? The researchers want it because they want structured data sets so they can get on and do their focused research in areas. The size of the bubble, though, actually reflects where we're spending our money. It's my contention that fundamentally we have a system manager agenda being run in the country. It's very much a technology-driven agenda. It's very little is being focused on the clinicians or the researchers. And in fact, I know the researchers are talking, but I don't see their interest in here yet. Where I think it has to be, this is the re-emphasis I think has to happen over the next 5 years. It doesn't mean to say that the system manager stuff doesn't get invested in, but if you think about it, InfoWay's got $1.6 billion. All of that is committed in relationships with provinces and territories. I think the latest figures, and I probably it's been updated, but I think about $900 million of it has actually been expensed, which means the rest of it is still sitting, waiting for the province to meet certain gates before funds flow. So there still is a lot of investment that's going to go into what I call the enterprise side. But I believe that right now, over this next 5 years, we've got to put a lot more emphasis on the clinician side, and this is where the patient and the clinical teams are working. And we've got to start putting more time and energy on the research, the knowledge developers to help understand what it is they need, so we can actually making sure that how we move out the system, we're trying to respond to their requirements. It's disappeared. Okay. So as we come at it, we say, as opposed to coming at it looking at the architecture, which is really what has happened over the last 8 years, we had this architecture and we're going to build it, we're saying, let's stop for a moment, take a look. What are the problems we're trying to solve? So I went to a number of clinicians across the country and people, and when we went through, and this is I call it a real sophisticated survey, but what they said is if we could deal with these issues, we think actually we could make some big gains. And we put up issues there that they felt, in talking to me, that with the type of investments we're talking about, of bringing more into the point of care and catchment areas, we could actually start to make some pretty good gains over the next 3 to 5 years in these areas. And in fact, there are metrics in behind here that can deal with it. So what does that translate by way of investments? And it's things I've talked about. One, IT enabling the points of care. And with either EMRs or in the long-term care, you're looking at sort of case management solutions. Taking a look at building a prevention clinical decision support module, and because there already is a compendium of preventative measures that have been derived from best practices and from evidence-based research. Build a module and give it away free to every EMR vendor and say, if you want, build it into your EMR, and it's based on what has come out of the evidence-based work, and that goes in every EMR. So you're actually enabling those clinical teams to better manage on the preventative care side. On the medication management, while there are modules already in a lot of the EMRs, we're saying let's make it even better. There's some good work that's been done by the Canadian Pharmacy Association and some of the work they've done. Let's put that together. Let's build a module, give it away as well. And you leave it up to the vendors to sort of integrate it or not. And if they integrate it, they have obviously a better product that a clinician would want to use. But what you've done is you've helped speed up those two areas where we know we can drive value back to the patient. Regional interoperability. Once again, let's get on with it. Get the standard done. And the other thing we thought is the telehealth network is good, but we need to grow it a bit more. And I think there's been some really, obviously the work that Dr. Ed Brown here in Ontario has done is a model of the types of stuff we'd like to see across the country. The last part is let's make sure we understand what works. The one in the middle, applied research on PHRs, there's a lot of talk about consumerism and how consumerism is going to be really supported by personal health records. To me, I don't understand how it's going to work yet. I talk to physicians who are working with patients who have personal health records and that are what I call loosely tethered, others that were tethered right into the EMRs, and we don't know what works best. And what I mean by that is how do a patient and a clinical team work together using PHRs to lead to better care outcomes, whatever that, and that's usually that's through the eye of the patient or the consumer. And I think we need to do some work here. To better help us understand across Canada what that means. There's some underlying things here that have been invested in, but we still need to work on. There's been a lot of standards work, and we should be committing ourselves to that as a country and stop the variations that we get ourselves into, because it drives up costs, and basically we're driving the costs into the vendor community, which I think is wrong. We should be continuing to push on the registries. And all provinces are working on this, but what I think we need to do is just accelerate that. Some have got it done and some are close. Getting the interoperability standard done, because we need that to actually drive out some of the connectivity. And we still think that the government's original broadband strategy needs to be refurbished, because we still do have some parts of Canada that do need to have a stronger broadband infrastructure to, in particular, support telehealth and moving on. So our view, if we go this way, what we're doing is we're rebalancing. It's not either or. It's a combination of a top-down strategy that sort of says put some walls around where you're going to play, and a bottom-up that actually allows you to figure out what works. And as I said, healthcare is a lot of art, and we don't know how best to integrate nor how to use IT to support clinical processes. And I think we have to accelerate that experimentation. We've got to leverage the current standards and registries that exist. And there's once good work there. I think I need a little more, but we're close. If we go this route, it increases the value to the patient. And this is, once again, improved care, safer care, etc. And we actually get it in a shorter time. Implementing EMRs is not a long-term issue. And once again, it's low risk and it's low cost on a per unit basis in comparison to some of the other things we're building out there. The other thing, it gives you more flexibility. The approach, if you do more bottom up, you're not caught into a big back end infrastructure that we're moving on, and you can actually adapt to some of the great stuff that's being done, stuff that's been worked on here at this university, other places where it's now in the market, it's off the lab bench, it's out there and it's working. And I'm saying, why can't we start to leverage some of that new thinking, new capabilities, and by not locking yourself into a big infrastructure buy in the back, it allows you to be a little more flexible on that front. So let me leave it there, and I'll turn it back to you, Shirley.
Okay. Well, thank you. So I'll open the floor for questions.
Thanks for a very good talk, Bill. Excellent. A couple of comments, and they're a bit flip, but it's to make a point. A lot of this stuff, the problem is we're trying to tackle a problem that we don't even understand. We need to factor it, as I mentioned earlier, into pieces that we can manage. Even what you've described is an awful big piece to bite off. One of the big selling points about EMRs or EHRs or whatever we call them this week was that they were portable. If you were in Paris, France, you could show somebody your record and wow, you'd get the world's best treatment, blah, blah, blah. That was a big selling point. You could solve that problem very easily. Most clinical management systems these days will hold some form of EHR. A doctor could have a box full of gigabyte memory sticks. A little application rolls off onto the memory stick along with your EHR so that if you plug it into any computer, it will show up. You know, you can have a pin in that in it to protect it if you want, that kind of thing. It seems to me that would create an awful lot of value immediately while we try to figure out what the next steps are. Because, you know, we've got OLIS in Ontario, and if that thing ever works, it'll be a miracle, I believe. That could be wrong, but I certainly haven't seen any evidence, and it's been going on for 10 years now. And just a ton of stuff like this. We're talking about a diabetes registry right now. Is that ever going to really happen? I mean, there's a lot of issues around it. So it seems to me, let's really start very simply and build out from simple. So just a comment.
Just on your point, by building out EMRs and putting them all the points of care, and particularly at the primary care level, because that's where the majority of information is going to be, we will actually give the physicians and the patients the capability of doing exactly what you want. So even without building what I call the local interoperability solution, by just doing that, we're actually giving more power to you as an individual, because now it's easy to, in a relationship with your physician or your primary care group, to say, what information would I want to carry with me? You don't want it all. I mean, if you look at what's in a physician's file, probably 90% of it is not much use to you, unless, let's say, you've got some very particular medical issues where you need that level of detail. So if you're snowbird, you're going down south, what you want to do is your demographics, your latest meds, any particular issues, allergies that you want to take, and you'd like to make sure it's matched in. So conceivably, you could have EMRs that actually the doctor and the patient set up, okay, what parameters will get, data points will get moved over, and every now and again, if you are going to go south, you go in, plug in your USB key, bang, you go off, and you've got it. So once you IT enable your primary care level, you've automatically have done that. And we can actually go there and get that stuff done very easily, and once again, low cost, low risk, and this is just a matter of moving that out. Because I mean, things like OLIS and stuff, you know, it's going to be a long time, I think, before that's going to come out. I mean, I'm hoping Greg Reed, who's the new CEO for EHealth, you know, I wish him well to sort of move that forward, but I mean, those are some big challenges that we're going to have in this system here. But I do think there's some, even with this agenda, there's some short-term real benefits that we can derive for the patient.
Martha, do you want to, there's a question from the web.
Yes. From Candace Gibson. Great. And think you are absolutely right in looking at this form, the point of care. Still would ask, who pays? If provincial money is tied up with enterprise projects, how much money left for assisting MDs, adopt records, and maintain them?
First of all, you've got 5 provinces that already have EMR programs in place, and they're moving them out, and they're probably going to be, for the next 2 to 3 years, fairly maxed out on their ability to move things out. The money that InfoWay has got, if you look at the budget, I mean, a good portion of it is going to be directed towards point of care, and what that'll translate into is supporting provinces of putting electronic medical record programs in place to sort of increase the level of IT enabling those points of care, that'll come. But my other point would be to the deputy ministers is, if you're spending all that money and it's going to take you a while to get there, why won't you take just 10% of it and put it down into your EMR program, where you can actually start to get returns in the next year to 18 months? And given that you've got all these cost pressures over the next 5 years, where you're going to have to really take a hard look at your healthcare budget, and you're going to have to cut, then you're actually starting to drive out value quicker. It may delay the longer term program, but at the same time, I mean, you're trying to increase the value, and therefore I think it's a reasonable trade-off to go that route. The other thing as well, I mean, I think we have to look at how we set up the economic incentives in the healthcare system. They are at times at odds, and I think if we're trying to promote people to act in certain ways, then we should be encouraging payment systems maybe based on accountability for delivering on certain services. And we're starting to see that. If you go down in the U.S., if you take a look at what the Office of National Coordinator is doing, their whole program is based on meaningful use. The reason I used effective use here, I'm trying to have a Canadian version of what they're doing. But meaningful use is basically all tied to you actually are showing you're using your EMR to deliver on care, better care. And I think that's one of the things we have to look in Canada too. So we're starting to tie accountability to payments, and I think that then drives up better value overall as well.
Thank you. Mr. Pascal, thank you for the excellent presentation. I wanted to ask you a question about the dynamics of the systems development at the enterprise level and some of the major players in terms of the providers, the vendors. What I've seen is the large ones, Siemens, Philips, IBM.
What?
They have incredible leverage in terms of saying, you look at a full suite, we'll be here forever, we'll be able to do it. Again, that point of care gets pushed further down, and the module by module development gets lower priority. And I was wondering if you could comment on that. The second thing is a more of a philosophical approach. Can you really do a long-term planning with such high capital requirements in a 5-year election cycle democracy?
I've only got 20 minutes. Let's get with your second question first. Interesting question, because, I mean, the political cycle is 4 to 5 years, and depending on what level of government, it may only be 2 years, and rolls over. And it does create a problem, because every government comes in and wants to see itself. Actually, if you moved it down, one of the benefits from where we're arguing is I could actually go to a deputy minister every 6 months and saying, based on actually bringing an EMR in and putting a medication management model and putting a chronic disease module, I've now, let's say on average, a physician has anywhere from 1,500 to 2,000 patients. I pretty well know what are chronic disease patients. If I take a look at the number of scripts, I can already start to say, this is the value you're getting. Now, no, it's an output value. It's not an outcome, but it's not a bad proxy for saying that if your scripts are now being written with a clinic decision support system on medication management, then you're pretty well guaranteeing you're starting to address some of the issues that may happen if you're not using it. So from a political point of view, I'm actually helping the minister show that he or she is getting value. Let's go back to a question, Don, you raised, which is on the diabetes registry. Fundamentally, if you have an EMR in an office that has a chronic disease management support system in it, a diabetes registry to a physician is of no use. Because if you go into a doctor's office now that has an EMR, they're already meeting probably close to 90%, 95% of the preventative measures around chronic disease management. Because they're using their EMR to work with their patient population to follow up, do your blood sugars, are you taking your test, it's time for you to come back in, etc. The registry actually is a political issue. It's helping the minister show what he or she is doing. So my argument with the minister would be, put all that investment into EMRs and then get a reporting back up to how that's being used in the clinics, and then we're actually showing in real time, if 6 months is real time in a political life, how we're actually supporting moving forward. So I think that helps to get at that cycle. The other thing too is by focusing it down, it goes back to the point of keeping your investment small, keeping short time frame, showing wins. I think is the way to go. It doesn't mean to say that the bigger stuff is not maybe necessary, but I would say, slow it down a bit. Let's move it down to the point of care, because I really do believe that there are other solutions for doing some of that, achieving the benefits that we think by getting big databases will have. To your point on with the big players and the full suite of things, I mean that's a decision of the provinces trying to go that route. I still even think in those, though, you could probably break them down and do smaller components and then take a look at turning pieces on. But it is higher risk, and it'll take longer.
I want to thank you for your talk as well. I work for a local software company. We focus on building products that enable the exchange of information between healthcare enterprises, be they hospitals or provinces or local practices. We've been involved in as you would call it, top-down level approaches. And I understand how those are funded. We have large-scale RFPs. There's a lot of money involved in a lot of companies. I very much agree that what we really need to do is we need a ground-up approach, like you've been suggesting, but even more than that, a ground-up, very incremental approach. My question is, how do we fund those things? We've actually talked to a number of local practices and hospitals and actually have solutions architected and designed for them. But what we find is everybody looks at each other for, is the hospital going to pay for this? Is the practice going to pay for this? And the amount of dollars required really to do this is so small. And we're really struggling with how do we get Canada Health Infoway or anyone to fund these types of projects so we can start to make that ground-up incremental approach.
Good question. If you take a look at the programs, the EMR programs, usually the funding is 30% from the physician, 70% from the governments, and that's usually, and that where that has come from. We've taken a look at it from sort of actually some work down out of CITL down in Boston. Sort of generally where do benefits flow in this? So physicians are committed, and usually when the family healthcare teams in Ontario come together, they're looking at how we bring that together. I'm not familiar enough with the types of solutions you were looking at, but certainly I would almost look at it as a regional investment, because I get a sense of what you're talking about is you're facilitating the flow of information, let's say, out of the point of capture through the healthcare system in a localized way?
As you suggest, it's between point-of-service providers and the places they refer their patients to.
Yeah.
So the question is, who funds interoperability between them?
And that's why my argument is go regional. Because my sense is if you wait for the provincial government to be able to build what they got, I mean, they got a ton of other things to do. They've got some big things. It takes time and energy to do it, and we have limited time and energy. These type of regional solutions, I think, get at what you have to offer. Yeah. And I mean, my recommendation would be is we take $100 million, we set up in a specialized fund, we have a standard, an interoperability standard that gets driven out through the standard collaborative because they're doing some great work, and provinces allow regions to actually go in and put a bid in for it. And as long as you build it to the standard, you then can actually look at an interoperability solution. That's where the funding comes for those types of things. And we start to grow it. And actually, I'd like to see a couple of pilots done. Let's prove it. And if it works, we continue to, if it doesn't, we tweak it. Try it again.
From the web?
From Dominic Covey. Dominic, it's an honor having someone named Pascal here in the Christian Holy Week. Dominic's question. You mentioned productivity increase as a desired outcome from our health investment. Could you define this? Dominic believes that the objective is both caring for more patients, doing so in the appropriate level of quality, and doing so in perhaps new virtual ways, not just pushing more patients through the office or hospital.
Yeah, I agree. productivity is one of those elusive things. I think there were some interesting studies down in the U.S. when we first started investing in the manufacturing sector that it took us 20 years before we actually were able to measure if we actually had productivity increases coming through. I'm not quite, and I think we have the same problem in the healthcare sector. I mean, my own view of it is, and once again, this is anecdotal because there's not what I call applied research. Having gone into clinics that have actually totally NR enabled, and I talk to them what they're doing, you do see, the quality has gone up in how they've worked with their patient populations. So to me, that's a product. They've increased the number of patients that they've actually have in their clinic now, and they're supporting. They've actually re-engineered the business processes in the clinic to provide better care. And what they've done is use the IT now to IT enable that process. In fact, the clinics that work best have actually done what normally most sectors would do, is you go in, you take a look at your business processes, you re-engineer them to make those most efficient, and then you IT enable that. So you're, as opposed to IT enable what you're currently doing and then try to reverse engineer it later on. So those are the types of things I see coming out. It's an interesting question, which I haven't seen anybody. InfoWay has put together a benefits cost framework, and in there's one dimension of it, which is productivity, and it's been done by a bunch of very smart people across the country who brought together some stuff. The problem is just that we haven't invested in trying to apply that model to see how does that help us actually measure a gain in productivity. And to me, that would be one of those things I'd love to see happen. And in fact, one of the things I didn't really point out, I think we need to put in place in Canada a substantial amount of money on an applied research agenda over the next 5 years, which actually goes in and really tries to dive into these things from a point of view, where are we getting better care outcomes? Are we achieving productivity? Can we start to measure it, et cetera? And start to bring that information to the fore, because decision makers need that to want to find out, are their investments sound, but also to help, if they are sound, it helps them stay the course to say, well, I do now see that I'm getting some benefit out of this, or the public is getting a benefit, or the patient is getting a benefit from it. So other than that, I'm not quite I can't add much more, but I think Dominic's right at the types of things we got to look at.
Hi, Karen Bell, Regional Project Manager in the healthcare IT space. And further, my question's further to the point of the software development person over there with respect to funding, and I think it has to do with the potentially, or your comments on the way that the Ministry of Health coordinates the operating budgets via the local health integration networks through to the hospitals, through to the CCACs, and then the funding for the family health teams and GPs, et cetera, is all independently done directly with the ministry. So then how do you pull together the operating funding to try and get something like that off the ground with the way that the governance is at the moment?
Move to another province. I've done a lot of work on Ontario. Ontario has a very complex system, and there's a lot of history in it, some of which I understand and some of which I don't. But I mean, the way they've set up the structure and the governance they put in almost dooms it to failure. And I hope my fellow colleagues at Ontario don't dump on me too much. But I mean, you set up the LHINs, but you don't collapse the hospital board. So now you've got a LHIN board, you've got a hospital board which is competing. You give the LHINs a bit of the money, but you don't give them everything to deal with. The hospitals keep certain stuff. The ministry keeps certain stuff. The ministry has a tendency, I mean, this is natural, to sort of put down and get involved in the operations, which is really not where they should be. So you've got an environment that actually creates tension. And quite frankly, I think Ontario has to step back a bit and revisit. I mean, how do you really want to organize your system here? If you do want your LHINs, and give them the power to do what they have to do. If you're not going to give them the power, then get rid of them and, go on to something else. Other provinces have it a little better, where some of the regions actually do have more power, et cetera. None of them have the negotiations with the practitioners, but even then you at least know what your cost structures are, because there is fee schedules that are attached to all that. But at least they've got more power, if you want, in making those types of decisions and guiding the direction. I mean, I just think working in Ontario is a very difficult task. I have no easy solution. If we could go this type of way, this type of funding, then maybe there is a way to actually start to fund some innovative experimentation and looking at how we can actually do some of that local stuff in a way that maybe ties into the LHIN, maybe ties into the CCAC. Don't know.
Just another comment. These huge databases that they're putting together, such as a diabetes registry, if you believe it has value, and I assume it has value for research, if nothing else. I don't know if it has any value for the patient. All that data is at the point of care now.
Right.
It could be easily gathered and funneled backwards into the database. That way the database might even be accurate. And again, this sort of fits in with what Rick said a few minutes ago. There's many local solutions that we could implement that are not that hard to do. And we could work backwards from the point of care rather than coming the other way.
I mean, it goes back to my comment of building in flexibility of how you build out your IT infrastructure to support your care. So let's take a look at that. If you take a look at some of the reports now, what you're finding out is that the EMR marketplace, has gone from, we've got about 40, but you've got about 6 or 7 big ones, and I'd say in about 5 years you're going to have about 4 big ones left. And what I mean by that, they'll probably have 85-90% of the marketplace. You'll always have some of the smaller EMRs there. And the reason that'll happen is because the new versions and specs are coming out. Those that have the strong P&L statements will be able to respond. Those that don't will fall by the wayside in there. If you think about that, if in the long term you only have 4 or 5 big EMR vendors, they'll all be ASP-based once we sort out performance issues. That means probably 90-95% of the health information on individuals is captured in those ASP operations. You could then set up on a regular basis flows of data in structured formats too. Let's say if the ministry said, I'd like to find out how we're doing in managing the diabetic patients, then you've got it. And actually you've got a source of truth, because the most accurate information is going to be with the clinical team that's actually working with that individual. And that's why I say having a diabetes registry up here is of no value to the physician if you've already got an EMR because you're already managing it. But you can, and you understand, we got to serve both purposes here. We got to help the minister demonstrate that we're doing some good things, and we got to support the point of care with the clinician and the patient that we're actually able to help them as well. So I agree with you.
From Dominic. As far as I'm concerned, the only significant use for a diabetes registry is to provide a single locus for identification and demographic data that systems can link into. Central care management just doesn't make sense, and it does not recognize the significance and continuing innovation that needs to occur. For example, to create capabilities that can facilitate patient motivation. I have a question from a participant on the web. I applaud your questioning of the status quo, but the model proposed still seems to rely on all of the large-scale projects that have skirted the point of care so far. Registries, HIAL, existing standards. Aren't we trying to have it both ways in this approach? How do we divert investments to point of care if we still require the superstructure for it to work? Doesn't going regional require the federal, provincial projects be abandoned and the funds diverted to regional efforts?
No. And let me explain why. Most of the all the work on clinically registries, provider registries, and location registries, by and large, has mostly been done. So those are investments that are there. And in fact, if you're going to run even if it's a localized referral, referral area, you need that information for patient identification, provider, where you are, et cetera. So this stuff, by and large, is already done or being well underway. So there's not a lot more investment to be done there. Standards, you need that. I mean, standards actually creates a smaller sandbox for you to play in, so you're not all over the place. And majority of standards have been done already. Building the interoperability standard, to me, is not a long-term thing, and it's not a costly issue as well. So those two things, to me, while they are necessary for the bigger system, they're also necessary to do this stuff locally, because you need that to sort of move information and make sure you're moving it into the right place. So I don't see the big issue. I come back to my point, though, that I think with taking a little bit of money that's being put into what I call the big enterprise and moving it down to the point of care, you still allow some of that stuff to go, the big stuff to go, if in fact you still think it's necessary, but you are also accelerating the point of care stuff. And you got to understand too, it's not just a money issue. It's a capability issue, because if you move money down into the point of care, there is a limit. There is a limit of a flow-through limit that's based on the capability of EMR vendors and others to do the work and get on with it. And the local integration. That's why I'm not a big fan of the Health right now, especially in large provinces, because it's a huge task. That's why I'd like to see us doing something more localized. The only reason I choose regions is it's got a governance structure around it that you can actually work with. You might even be able to do it smaller, but I think just from a political acceptance point of view, you're probably looking at something that has a bit of a governance structure that a minister says, I'm willing to work with that group because I know them. I might not want to work with a smaller subset because I'm not sure who they are and whether making that investment makes sense. So I'm not quite there with the question that the person put in.
Well, I'd like to ask a question, and that is, as your role in the CMA, what do you see the CMA's role in all of this? Where do you see that you can really have the most impact in making this change?
I mean, the CMA's got two main mandates. We're a policy shop and we're an advocacy shop. We do a lot of policy work on issues in the healthcare system where we believe that changes have to be made, where we think that things have to move on. And we leverage our capability in the advocacy to try to move those ideas out. Now, obviously, I mean, given who we are, we have a tendency to look at through the eyes of the physician as, the feedback we get from physicians is, help us deliver better care. What can we do? So we're trying to sort of translate that into activities that we do. So our role in this is that, we're commenting on what we're seeing happening out there because we don't think it's actually a good investment at this point in time, the way it's going, because it isn't really driving value to the patient. If you talk to a physician, the reason that they bring in technology into their clinical processes, they believe it's going to lead to better care for their patients. And they also hope it's going to help them manage their office better. But I got to tell you, the research we've done on the 20 case studies, it really demonstrates that all those physicians and clinical teams said, yes, we're doing better on the care. The cost side is a whole other question. That one doesn't really come out. So that's the role we see ourselves playing, and we'll continue to play. We'll continue to comment on things that we think need to be adjusted, need to change, and we're working with a whole group of people across the country to do that. I mean, we're not just doing it by ourselves. So we work with groups like the Canadian Nursing Association, Pharmacy Association, the Canadian Healthcare groups, other organizations, to try to sort of keep the system in Canada evolving. We do worry a bit that the federal government's pulling back from wanting to be a more activist player in the country, and we think somewhere has to keep a debate going on issues. And in particular, given the cost pressures we got, that we really have to have a good, honest debate on how do we go forward with our healthcare system.
One final question here.
My name is Sohail. I'm an interoperability specialist. And first of all, thanks very much for your presentation. I kind of see the point of the previous question and agree in some ways because I can see a lot of complexity. While it's a very simplified conceptual overview, but interoperability becomes much more complicated in this model, especially the ability to find uniqueness in certain things, whether patient, provider, locations, medications, and so forth. Looking at our infrastructure today as registries, I don't think they would be able to support such interoperabilities. What I'm hearing as far as the statistics for Ontario, which we're supposed to have roughly 12 million unique records in registry, we have more than 20 million records. So these are some of the points, and I'm not sure if provider registry has been completed or any other registries for that matter. So what do you
It depends on the province, but certainly a lot of the client provider registries are already in place and working. And actually, there are experiments going on already where we are doing some local interoperability. It's been sort of what I call skunk works, where people have actually made it work. It is doable. And there's a number of companies that do interoperability solutions that are active and already doing that. So it's not something that we picked on because we thought it's a neat idea and it hasn't been done, but it already has been done. And I guess I'm from the school, let's get very pragmatic, let's try something, let's see if it works, as opposed to thinking, let's build the big thing and then when we flip the switch, is it going to work? The odds are it won't, and it's not because it's just the complexity of it. So I guess I'm not quite where you are on it. I do believe it makes sense. Maybe we have to pilot it in a smaller area, but let's get on and try it.
I think it's a good idea. It's just integrating all these different softwares are going to be just more difficult than integrating a few registries on an EHR.
Well, I want to thank everybody for coming here today for this presentation by Bill. I've really enjoyed your presentation, Bill, and I love the discussion afterwards. So thank you all for participating in the discussion and coming here today. I want to give Bill a small token of our appreciation for him coming here. And I hope to see you again in the future at one of our future seminars. And please come to the conference. I think you'll all enjoy it at the School of Pharmacy at the end of April. So thanks once again.